I am Dr. Gary Rogal, Medical Director for RWJBarnabas Health Cardiovascular Services. It's my pleasure to moderate this important and hopefully impactful conversation. And our conversation is occurring in the context of hopeful signs regarding COVID-19. New infections appear to be down, hospitalizations are down, and a very positive sign is noted in the UK. Although a variant of COVID-19 has emerged there, it appears that the trends are tracking those noted in the United States. But a note of caution is important with COVID trends, as it is with cardiac health issues in general. Both require constant vigilance. It is so easy to backslide and so tough to regain lost ground once lost, and new data is available all the time. But one important message demands emphasis. Do not delay seeking medical attention for new symptoms, as we observed during the first wave of the pandemic. Before we pose questions to our panelists, allow me to outline some thoughts regarding heart health. And here is a usual disclaimer: you will want to consult with your personal physician regarding your particular situation and the information that we discussed tonight. Our comments tonight are based on our current knowledge regarding cardiac health and general well-being, but I would suggest that perhaps we have selected the wrong title for this webinar. Your heart health affects your global health, to be sure, but your global health strongly impacts the state of your cardiovascular system. Diabetic patients know this well as they work with their physicians to control their blood sugars. Poorly controlled diabetes affects virtually all organ systems, including the cardiovascular system, and often prevents those patients from employing strategies that maintain good heart health. Disease of peripheral blood vessels, neuropathy or disease of nerves, orthopedic issues severely impact the diabetic patient's ability to maintain heart health despite their best efforts. And let's not forget one other major factor when considering caring for the heart. A smart teacher of mine was fond of pointing out to her cardiology fellows that the heart and the brain are closely connected. This may seem obvious, but we know that there are examples of psychological impact on heart function. Years back, the Japanese described a syndrome related to severe psychological shock resulting in what appeared to be a massive heart attack. It is called Takotsubo syndrome. This was originally described in patients who had experienced a devastating psychological blow, in some cases the sudden death of a loved one or some other psychological shock. This is a very extreme example of how psychological state may affect our cardiovascular system and serves as a lesson that attention to global health is critical when thinking about maintaining heart health. And there are, of course, studies that suggest that stress reduction can have a positive impact on cardiovascular risk factors. So perhaps we should be discussing global health status and the heart. How do we maximize both? In discussing heart health status and the heart, it is important to put the conversation in proper context. COVID-19 has shown us that we are presently living in an explosion of medical science. It took years to develop the polio vaccine and months to develop the mRNA vaccines that will soon pull us out of this pandemic. True, it did take much added time to test the vaccines, and that is still our weak point in medical innovation. But here we are with a solution to a massive public health problem in the space of just 1 year. And it may be that this RNA technology will have some applications to the cardiovascular system as well. But as a cardiologist, I would have never thought that the aortic valve could be replaced through a catheter without major surgical invasion of the chest, a procedure called TAVR, or transcatheter aortic valve replacement. And just this past month, one of our patients was discharged just 12 hours after a TAVR procedure. Similar advances for the mitral valve are on the horizon and in trial in our system now. Our electrophysiologists implant devices that not only treat rhythm disturbances that may be lethal, but also monitor many measures of heart function, allowing us to intervene before clinical issues begin. They also implant devices to prevent clots from forming in the heart during atrial fibrillation, excluding the need for potent anticoagulants. And speaking of anticoagulants or blood thinners, we now have much safer drugs to give to patients should anticoagulation be required that are more simple to use and less impactful on lifestyle. Heart pharmacology has made major strides in the last 10 years. We are living at an inflection point as much of cardiac care moves to the outpatient arena. Treatments are less intrusive, and certain cardiac conditions are no longer life-threatening. As a result of this progress, and at this inflection point in medical science, cardiac services at RWJBarnabas Health is turning in a new direction. while maintaining a robust program to address acute episodes requiring urgent or emergent intervention, we recognize that early risk identification, risk reduction, and intervention stand the best chance of improving our patients' lives, both in quality and in longevity. Our goal is to tie our inpatient and outpatient operations together in a tighter fashion than ever before in order to efficiently deliver care, no matter where a patient may be. Said another way, where a patient may be, home, hospital, or in one of our outpatient settings, becomes less important than efficient delivery of high quality care, pulling the assets and information from all of those sites together. But how the system is arrayed to deliver care is only half of the equation, and the other half really is all of you. I often tell patients that as their physician, that I am only one half of the solution to successful health maintenance. Patient empowerment goes a long way towards maintaining quality health and fostering longevity. Equally important is a discussion of the obstacles to patient empowerment, a subject that has little data to inform our decisions regarding patient care. But let me share with you some observations that may be helpful in your thinking about your ability to blunt the course of chronic cardiac conditions. It is now well known and supported by clinical data that small amounts of activity have potent effects on the heart and the vascular system. One study suggested that even trivial amounts of activity has a large impact on cardiac status. And as that activity is ramped up in time and intensity, the benefits increase as well. So in the case of the diabetic patient that I referenced above, even if unable to sustain activity for no greater than 15 to 20 minutes, activity for this short duration still has important benefits. In other words, you do not have to do a 5K race to derive benefit from physical activity. And in my experience, the reason why people quit exercise is that they feel that small amounts offer no benefit. No pain, no gain is not valid in this discussion, and throwing away even modest amounts of physical activity is surrendering a powerful tool for heart health. Let us consider another common, if not the most common, obstacle that patients face when trying to maintain global and cardiac health. You may be familiar with studies that show that productivity in the workplace has been shown to increase when the work week is shortened to 4 days instead of 5. That bit of data has important implications for patients who claim that they do not have the time to do all that is necessary to maintain their cardiovascular health. It may be that the more work that you do, the less productive that you actually become. Why not take that less productive time and spend it with taking the time to eat properly, exercise, and practice stress reduction? Your work will not suffer, and in fact, it might improve, and certainly your health will improve. Then there are family members that we all have to take care of who need our constant attention, taking time from our daily routines. Our ability to help them is proportional to our own health, and time taken to make the caregiver stronger only serves to make the caregiver more effective in this important role. What do they tell you when you board an airplane? For those traveling with children, if the cabin decompresses and oxygen is required, put yours on before your child's. The reasoning is obvious, but not so obvious to us in our daily lives. All this may sound unimportant. After all, I'm not talking about high-tech procedures or fancy diagnostic tools, but what I am talking about is just as important to your health. Your physician is responsible to you as your guide to better health and well-being, but you are responsible to yourself to utilize all that is available to you to make you a strong and healthy individual. If you leave your physician's office and she or he tells you to cut the carbohydrates, check your blood pressure at home, do not add salt to food, walk 30 minutes per day, 5 days per week, and stop eating processed foods, and you do none of it, what do you expect to be the outcome? It's like going to the physical therapist for back pain, getting treatments, feeling better, but not doing your exercises at home. What do you expect the outcome is going to be? Guaranteed more back pain. The problem is that the consequences of ignoring your cardiologist are significantly worse and more insidious than ignoring your physical therapist. With that said, tonight we put together a panel of experts in all aspects of heart care to share with you their insights in 3 important areas: sports cardiology, women's heart health, and cardiac risk factors and atrial fibrillation. Joining me tonight are 3 distinguished colleagues, people I've worked with for many, many years. Dr. Jeffrey Lander is a non-invasive cardiologist with special expertise in sports cardiology. Dr. Jacqueline Schwanwede, a non-invasive cardiologist with special expertise in women's heart health, and Dr. Frederic Sardari is Vice Chairman of the Department of Cardiothoracic Surgery, St. Barnabas Medical Center, with a special interest in surgical adjunctive therapies in atrial fibrillation. So I'm going to turn it over to Dr. Lander now, who will speak to you about his expertise in sports cardiology.
Dr. Rogal, thank you for the introduction. Heart Month always provides a great opportunity to discuss the important aspects of heart health. And the two topics that we'll talk about for the next few minutes are sports cardiology, and then we'll shift a little bit and talk about COVID-19 and the heart. So let's start with sports cardiology. And often the first question is, what is sports cardiology? Well, it encompasses the cardiac care of athletes and active individuals. The heart's a muscle, and just like any other muscle, when it's exercised, it adapts and changes. So a sports cardiologist is a doctor who's familiar with these adaptations and can differentiate the normal changes related to sports from changes that may be related to pathology or an abnormality. Doctors in sports cardiology have special expertise, and not only cardiology, but also understanding the physical demands of competitive sports, as well as the psychology of athletes. The next logical question you probably have is, who do sports cardiologists see? Who can be seen in a sports cardiology center? Well, this varies. It can range from someone who's having symptoms during exercise to evaluating someone who has known cardiovascular disease, who may want to start exercise or even ramp up their current exercise. We often screen athletes prior to participations in different athletic events. We evaluate active individuals who have a family history of cardiac disease. And in general, our goal is to keep highly active individuals safe, healthy, and performing well, both on the field and off. At our sports cardiology program at St. Barnabas, we see all levels of athletes. That includes professional athletes, collegiate athletes, school-aged athletes, the weekend warriors, and of course, the masters athlete. We work with an interdisciplinary team to take care of the athlete and active individuals at all levels. And here, I'd like to shift a little bit and come away from sports cardiology and talk about COVID-19 and the heart. Some of the most common questions I've gotten during the pandemic from patients, from friends, from family, are in regards to COVID and the heart. Early on in the pandemic, we learned that compared to the general population, people with underlying cardiovascular disease are significantly more likely to contract more severe forms of COVID-19. Lately, even though the death rate from COVID-19 has dropped, cardiovascular disease remains a major predictor of poor outcome from COVID-19. Now, there are a few ways cardiovascular disease increases the risk for severe COVID-19. Now, it can be challenging enough for a healthy heart to deal with the stress of COVID-19. But if someone has pre-existing heart conditions, such as a blocked heart artery or weakened heart muscles, it may make it more difficult to survive the stress of COVID-19. During the infection, the body may have to deal with issues such as a low oxygen level, low blood pressure, or clotting problems, all of which pose significant risk to the heart. And not uncommonly, people who have cardiovascular disease also have poor metabolic health, often caused by diabetes and obesity. And these in and of themselves can cause inflammation and increase the risk of blood clots, which can exacerbate the effects of COVID-19 and increase the risk for significant complications. Now, not only does cardiovascular disease increase the risk of serious COVID-19, but on the flip side, COVID-19 can actually cause heart damage. And it can do this in several ways. One way is the virus can directly injure the heart. Another way is via excess inflammation. So the body's natural response to infection is inflammation, but sometimes the body's response is too much. In particular, the body releases inflammatory molecules called cytokines, and these certainly can be helpful, but if there's too much, this is called a cytokine storm and can affect organs, including the heart. Additionally, COVID-19 can disrupt the balance of oxygen supply and demand in the heart, which would injure the heart. Fever and infection increase the heart rate, which makes the heart work harder in COVID-19 and require more oxygen. Low blood pressure seen during COVID-19 illness can put further stress on the heart. And during COVID-19, the body's more prone to developing clots. And if a clot is formed in one of the arteries of the heart, this can deprive the heart muscle of oxygen, which can cause a heart attack. However, it's not all doom and gloom. Optimization of cardiovascular health can not only decrease the risk of complications from cardiac disease, but may actually mitigate vulnerability if a person is exposed to COVID. So it's extremely important if you have underlying cardiac issues, you want to continue to manage them along with your doctor. I know that some people certainly have been hesitant during the pandemic to visit their doctors, but again, it's extremely important to continue to care for your heart and your health, as Dr. Rogal mentioned. Now, I can assure you, your RWJBarnabas health doctors have taken the utmost precautions to keep you safe during the pandemic. So I'll remind everybody, please remember, wear a mask, wash your hands, distance when possible, and when eligible, I certainly recommend the vaccine. And with that, I'll turn it back over to Dr. Rogal.
Jeffrey, thank you. Thanks very much, Jeffrey. Very informative. We do have a few questions that we've collected. So the first question I wanted to ask you about, and this is a kind of a common thing as practicing cardiologists we get all the time. What are the basics for screening athletes, in particular high school athletes for competitive sports? What are the basic bottom line things that pretty much every athlete should have done before they participate?
Sure, it's a question I get a lot, really. Who should be screened? Which high school athletes or athletes in general who should be screened? Yeah, I feel that all athletes really should undergo cardiac screening. Now, this doesn't necessarily mean a visit with a sports cardiologist. It could be a visit with their primary care physicians. We're actually lucky here in New Jersey because New Jersey was one of the first states that required our student athletes to have screening prior to participation. And not only do these student athletes have to have screening, but if the doctor wants to be able to do the screening, they actually have to watch a module that educates them about issues in athletics. Kind of as far as a bare minimum goes for what kind of screening, I certainly would say a history and physical exam are both musts when screening the athlete. And oftentimes we will add on an EKG as well. Now, those are really the basics, and depending upon what we find there, we may prompt further questions or further testing.
All righty, thank you. So another question that we're all getting now is, patient comes to you, they had COVID 6 months ago, or even 3 months ago, and they want to know if it's safe for them to return to play. I'm talking about now college athletes, kids playing lacrosse, field hockey, pretty competitive stuff. What do you tell them about their participation in that kind of intense activity?
Yeah, sure, that's a great question. And just like you mentioned, we're seeing tons of it. I'm really seeing it every day in the office, all levels, from professional athletes, the college athletes, the high school athletes. I feel that all competitive athletes should be evaluated by a physician prior to returning to play. But similarly to what we mentioned just earlier, it doesn't necessarily mean a sports cardiologist. It could be their pediatrician, their family physician, an internist, or their sports medicine doctor. First and foremost, prior to returning to play, the athlete must be asymptomatic. And depending upon how severe their COVID-19 symptoms were, this will guide us on what we need to do next as far as an evaluation and timing of when to return to play. So for the asymptomatic and the mildly symptomatic athlete, these likely won't need any further evaluation beyond a history and a physical. However, the athlete who's had more moderate or severe symptoms, including if they were hospitalized, these are the athletes who we're going to want to visit with a sports cardiologist, and often additional testing will be required. But just like you mentioned earlier, it's important to remember that we need to individualize each case, and specific recommendations certainly may vary. But whenever the athlete is ready to return to play, there should be a slow, graded return and not just a jump right back to it full throttle.
Jeffrey, thanks very much. That's very helpful. And thanks for your comments tonight. Really terrific. So we are going to turn now to Dr. Jacqueline Schwanwede, who's going to give us a little discussion on women's heart health and what are the key points there.
Okay, thank you, Dr. Rogal. So the first thing, so February is Heart Month, and Go Red for Women is the American Heart Association's program to remind women that cardiovascular disease is the leading cause of death in women. It kills one out of three women, more than all combined cancers known at this point. The question is, it's not just a problem for older women. Heart disease and stroke can affect a woman at any age. So new research shows heart attacks are on the rise, in younger women. That's why it's very important for all women to take charge of their heart health and be aware of their risk factors. So awareness is absolutely key. In 2020, a study showed that about 44% of women were not aware of their risk factors for cardiovascular disease, which is pretty impressive. So what are those risk factors? Hypertension. Normal blood pressure should be 120/80 approximately. Diabetes. Women with diabetes are more likely to develop coronary artery disease than men, and also put them at risk for silent heart attack. Smoking, best not to start smoking. A family history of coronary disease, this is important. Obesity, know that a BMI greater than 25 is considered overweight, and a waist circumference of 35 inches in women and 40 inches in men. High cholesterol, inactivity. The American Heart Association recommends about 150 minutes a week of moderate exercise, and that can be just walking. Stress, mental stress and depression can definitely contribute to an unhealthy lifestyle. It's important to remember that those of us who have a family history of heart disease can make an impact of over and up to 80% to reduce the risk of heart disease with a healthy lifestyle and modifying our risk factors. Blood pressure, if ignored, can quietly damage your body for years before symptoms. Uncontrolled hypertension can lead to heart attack, stroke, and heart failure. Hypertension damages the cells, the inner lining of the arteries, and contribute to the narrowing of the arteries. And it also can actually weaken the wall and cause aneurysm. So we can prevent hypertension by controlling our salt intake. Researchers have shown that reducing sodium intake can lower blood pressure. Also keeping our weight under control and exercise. If you do all of this and your doctor still feels you need medication to help with control of blood pressure, then take the medication as instructed. So it's a team approach. How much salt? Probably don't need to use a salt shaker, and should restrict processed foods, some cheese, olives, some other natural foods. American Heart Association states no more than 2,300 milligrams of salt a day, but if you're hypertensive, no more than 1.5 grams or 1,500 milligrams. When eating restaurant foods, request preparation with decreased salt. So what is healthy eating? That could improve intake of fruits and vegetables, increase that, decrease fats, decrease sugar, sugary drinks. Let's see. Just to know that heart disease up until a few years ago was thought to be a man's disease, but just as many women and men in the United States have heart disease, and it is the leading cause of death in women. It's important for providers to make sure to educate their patients of the risks and their signs and the symptoms. It's important to reach out to poorer communities with education and with care. Prevention and education is the key to preventing heart disease. Signs and symptoms in women can be different, but the most common heart attack symptom in women is the same for men: chest pain, chest pressure, chest discomfort. But women also can have discomfort in the neck, shoulders, upper back, abdomen. They can have shortness of breath. They can have nausea, vomiting, severe fatigue, feeling sweaty, lightheaded, dizziness, just plain old not feeling well. Women tend to put their symptoms aside and not seek help. They can have symptoms at rest, figure they're just tired. And also was mentioned, emotional stress can trigger heart attack symptoms. Many women don't recognize their symptoms as a heart attack and put off seeking help. And when they show up in the emergency room, they already have had heart damage. Women need to seek help immediately if they think they're having heart attack. Call 911 and understand that it is very safe to go to the emergency room. The emergency room has made big efforts to make it very, very safe during this time of COVID. Make sure that you visit with your physician. Make sure that you have regular checks and be aware of your risk factors. Thank you very much.
Couple of questions for you now. I want to go back a little bit and talk a little bit about the distinction between the symptoms that a patient may have warning them that they could be at risk for a heart attack versus the actual symptoms of a heart attack. And you know, I think what a lot of us have seen is that it's really the warning symptoms that can be missed and somewhat atypical. Could you comment on that?
Sure. Many women, I'll pick on women because I see them the most, will notice increasing fatigue, but more so than they've noticed before. Most of everybody will say, well, yeah, I'm tired, but just not being able to do slowly, not being able to walk the distance that they normally walk, or take the laundry up as easily up the stairs as they normally can. It's a little short of breath, or feeling dizzy or lightheaded. So, and that it'll happen once and they'll put it aside, and it'll happen again. Sometimes that those are the things that they need to watch for, even though they're symptoms that are non-specific. But if it's a particularly healthy person who normally doesn't have any problems, they should pay attention to it. Or pay attention to what's different about their body. The women tend to put it aside and worry about the other people in their families. So anything that's different, they should at least reach out to their provider, to their doctor, and see, you know, is there something going on. So, because by the time they do have a heart attack, the symptoms are intense. I've asked women in the emergency room, well, what made you finally come? And then the history will come out that it's been going on for a while, and they've ignored it.
So what a symptom of a heart attack that a woman should never ignore? Tell the audience a couple of those.
Okay,
so things they should never ignore.
Definitely shortness of breath. Definitely pain between the shoulder blades, discomfort that actually is in their jaw, in their neck. That's important. Intense fatigue, sweatiness, lightheadedness going along with the intense fatigue. Sometimes that indigestion, particularly if you don't have indigestion, those would be something that would make me pay attention.
Okay, so I have two more questions for you real quick before we go on to our next speaker. I often get the question, do interventions like angioplasty, stenting, and bypass surgery, do they work as well in women as they do in men, or is there a disparity there?
The only disparity is that sometimes they're not done as quickly, or in the past. That was in the past. They work as well. To take that back, sometimes in elderly women, there might be more complications. But if timing's right, they can work as well. At least in my experience. And I'm sorry, what was the other part of that question?
Well, no, I have a second question, which I promised a couple of my friends I would ask you. And that question is, who's easier to work with, men or women? Careful
okay.
now.
All right, so I think that men may follow directions better than women. I've had more women show up in my office who have decided to not take their medicine because they felt like they didn't need it. But on the other hand, I personally have told my husband to go to the emergency room when he was having a heart attack, and he didn't go.
Oh, and you're a cardiologist.
Mm-hmm.
Okay. All right, Jackie, thanks very much. We really appreciate your comments. So Now we are going to turn to our cardiac surgeon, who's been surrounded by cardiologists this evening so far. And Dr. Frederic Sardari is going to speak to us about atrial fibrillation and therapies that the surgeon might have to offer patients.
Thank you, Gary. Yes, I'd like to talk about atrial fibrillation because I believe that it's a very important topic because on the one hand, it affects millions of Americans. There's an estimate that by 2030, there'll be over 12 million people with atrial fibrillation in this country. And on the other hand, there are new and exciting treatment options that are available now to the patients, and patients really need to know about them. And their care providers also need to be educated to the newer methods that are available and should be offered to the patients. So just to go over the basics a little bit, what is atrial fibrillation? It's a irregular, abnormal heartbeat that originates in the chamber of the heart called the atrium. And it's caused by an abnormal electrical signal, which then propagates to the rest of the heart and makes the heart beat irregularly and generally too fast. And that's what atrial fibrillation is. I'll refer to it more commonly as AFib, but same thing. So the symptoms of atrial fibrillation vary. It can be nothing, completely asymptomatic, to a patient feeling it very strongly with dizziness, sweating, lightheadedness. Most patients will feel some kind of palpitation, but won't feel too sick from it. The important point here is that atrial fibrillation is very much like high blood pressure, like hypertension, in that you can have it and not know that you have it, which doesn't make it any less serious. Whether you feel it or not, if you have atrial fibrillation, it needs to be treated and cannot be ignored. So what is the risk of atrial fibrillation? Generally, the risk of mortality with somebody with AFib compared to somebody with no AFib is about twice the rate of mortality. The risk of stroke in a patient with AFib compared to the general population is 5 times greater. And the reason stroke happens in the patient with AFib is because during fibrillation, the heart doesn't squeeze normally. The blood flow is abnormal in the heart, and the blood can stagnate. When the blood stagnates, you get clots that can form, and those clots can travel and go to the brain and cause the stroke, which is the worst complication of atrial fibrillation. Of note, there's one part of the heart that's more prone to developing clots, and that'll make more sense when we talk about the treatment methods, and that's called the left atrial appendage, in case patients hear that term. The other reason why AFib is dangerous and the risk of it is that there's a 5-fold increase in heart failure. Patients with chronic, long-standing AFib are prone to developing heart failure. The very important point about atrial fibrillation is that it's a progressive disease. It starts with intermittent short bursts of AFib, which can last just a few minutes and disappear. But over time, over months, over years, it increases in frequency, in length, till eventually it becomes permanent and chronic. That's the other end of the spectrum. The point here being that if it's caught early, AFib can be treated much better. And the fact that AFib, the patient is not experiencing much AFib or very infrequently experiencing it, does not make it any less dangerous or any less urgent to treat, because if it's not treated, it will progress and become dangerous for the patient. So let me turn to the treatment options now. So the traditional treatment for atrial fibrillation is anticoagulation, blood thinners, so as to prevent the worst complication being strokes. There have been, as Gary mentioned, some improvements in the medications, but still anticoagulation, blood thinners have their own complications and are not always well tolerated, especially in elderly patients. The other thing that's traditionally been used with AFib is a medication to reduce the heart rate and medications called antiarrhythmics to try and decrease the amount of AFib. A more recent treatment for atrial fibrillation is what's called ablation. And essentially what ablation is an attempt to isolate the area where these abnormal electric stimuli come from, isolate that area from the rest of the heart, and that's done through either heat energy or cold energy. In other words, the surrounding tissue is either burnt or frozen. Ablation is most commonly done through a catheter, but it can also be accomplished with minimally invasive operations or a combination of the two. And finally, the last and most recent addition to the treatment options for atrial fibrillation is management of the left atrial appendage, which, as I mentioned earlier, is the one area of the heart that's most prone to develop blood clots and cause strokes. The left atrial appendage is a small outpouching of the left atrium, which can be closed off in various ways, or tied off or sutured off. Again, it can be approached in different ways. It can be most commonly approached through catheter procedures, and that's what's called the Watchman procedure, with great results. If that's not available or possible technically, it can be done through video-assisted thoracic minimally invasive procedures. And lastly, it can be done as part of a bigger open heart surgery as a concomitant addition to another cardiac operation. So these are the treatment options, and really the message here for atrial fibrillation is that no matter how severe it is or when it started, it needs to be treated aggressively. There are newer options to treat it, whether it's early in the course of the disease where ablation can be used to eliminate it, or whether it's later in the disease and the patient's had it for a long time but doesn't tolerate the traditional treatments such as anticoagulation, the blood thinners, and then we have options to take care of the left atrial appendage and either reduce or eliminate completely the need for blood thinners. I think we'll go to questions now.
Sure. Well, that's a lot of information. That's a real lot of information. Thanks, Fred. Just to be clear for our audience and the folks who are listening, you end up as a cardiac surgeon seeing these patients. You see pretty sick patients. You see patients at the far spectrum. Us cardiologists, Jackie and Jeffrey and myself, we see patients who are considerably younger. It is true you can have a perfectly normal heart and have atrial fibrillation, correct?
That's a tricky question, I feel, because yes, it's true that you can have a normal heart and have atrial fibrillation, but it doesn't mean that atrial fibrillation should not be investigated and treated. Whether your heart is normal or not, you're still prone to having the increased risk of stroke. So evaluation and testing is required. And as I said, it can be a progressive disease, so it cannot be ignored.
Right. So in most, it should be investigated, certainly, but there are a lot of patients out there with atrial fib who could lead very normal and productive lives. Is the kind of the point that I wanted to make sure everybody understands. Another thing that I'm interested in discussing with you tonight is you've been very into a multidisciplinary approach for this problem. Could you talk a little bit about the people that you work with on the team at St. Barnabas Medical Center? What types of physicians that you work with for the multidisciplinary approach when you're taking a patient to the operating room?
Well, primarily with the cardiologist that refers the patient. And so there's really two scenarios. One is a patient that needs surgery for a valve or a bypass. And then with the cardiologist, we'll discuss whether the patient had any sign of atrial fibrillation, any occurrence in the past. And if that's the case, then it's important for us to know so that we can take care of it at the same time. Because with the newer techniques, we can take care of the, the ablation very easily during the operation with no additional risk to the patient and take care of that problem. So that's the most common scenario, but there's other situations where I work directly with the electrophysiologist, like Dr. Dobish at St. Barnabas, where patients have had ablations before, but the ablations have not completely treated the problem. And then we add a minimally invasive surgical procedure to complete the ablation. And the combination of the two as a hybrid approach has very good results, achieves 80 to 90% success.
And I'm sure Jackie and Jeff would agree that while you taking care of AFib in the operating room, it makes our life a lot easier for sure. I think that's really very true. Just expand a little bit on the Watchman procedure, how it's done, how long does a patient stay in the hospital, what are the risks? Just discuss that briefly if you would.
Yeah. Well, the risks are surprisingly low, but essentially this is a device that's goes up through the veins and through the septum of the atrium, and is placed inside the left atrial appendage, which, as I mentioned, is where the clots can occur, and essentially blocks it off. Once that is in place, the patient still needs to have some anticoagulation for a few months to make sure that it's in proper position and it's sealed off, and then can drastically decrease the anticoagulation.
Yeah, so this is most useful in patients who really can't be on anticoagulation long term, correct?
Right, exactly. That's exactly those patients, and we're seeing a lot of those patients because it's generally a disease of the elderly, and the elderly often have a problem with anticoagulations. Sometimes the Watchman procedure is technically difficult, or the patients absolutely cannot take any blood thinners immediately. And then we offer the surgical approach, which is through a video-assisted operation, minimally invasive, where the appendage is actually clipped from the outside. And with that, anticoagulation is not necessary at all. It can be stopped immediately.
Yeah, that's a terrific solution. All righty. Thanks, Fred, very much. Again, that's a lot of information. I really do appreciate those comments. I think we're going to throw it open now to some closing comments, and let's go in order to how we began, and we'll start with Dr. Lander, maybe just a couple of seconds. Any other comments you might want to add, Jeffrey, to either what you said or what anybody else commented on tonight?
Sure. I'll just add on that there's a large and growing number of people in the U.S., in particular New Jersey, who are involved in competitive sports or athletics, exercise at all levels. And this is a great thing. We all know the heart benefits that exercise has, among a myriad of other benefits. Sometimes questions or concerns, changes may arise. And if they do, please don't hesitate to reach out. We're here for you.
Great. Thanks, Jeffrey. Jackie?
I just want to reiterate for our patients to be aware of their cardiac risk factors, to make sure that they're checked on a regular basis by their primary care physicians, to ask questions if they notice changes in their health, to exercise, keep their weight under control, and to take control of their health, and to stay safe during the pandemic, wear their masks, and wash their hands.
I think that's great advice. Well, Fred, we just finished, but is there anything else you want to comment on about AFib or anything else in your surgical world?
No, just really to reiterate that there are newer treatment options for patients, and even patients who have had AFib for many years, who have been told that there's really no other option but that they have to take the blood thinners, that they should really talk to their doctors to investigate if there are other newer options to take care that could take care of their problems.
Okay, terrific. Thanks. And I'll just kind of close out the session by saying that after 3 decades of practice, one thing that I've learned that is incredibly important is that the patient, all of you patients out there or folks who are watching, it's extremely important that you take up your half of this whole equation, because it's not just the cardiologist or the surgeon, it's going to be you also who are going to be responsible for your care and can make an enormous difference with very little effort. So with that, I'll thank all of our panelists, Dr. Lander, Dr. Schwanwede, Dr. Sardari. I'd like to thank all of you for attending tonight. And everybody, again, wear your mask, wash your hands, and hopefully the spring will all be a lot happier. Thank you.